happy that Dr. Mustanski came to see us. Dr. Brian Mustanski is here. He is a tenured professor of medical social sciences at Northwestern University in Chicago, Illinois. He's the director of Northwestern's Institute for Sexual and Gender Minority Health and Wellbeing, which has a mission to conduct translational research that improves the health of the LGBT community and train the next generation of LGBT scholars. In fact, I think I remember this is one of the first centers like this that is co-funded from the university. And we have a clinical center attached to it, right? So it's really a unique blend and an example of a university, I think, investing in research specifically on LGBT people. That's an important model, I think, in the United States now. The majority of his research focuses on the health and development of LGBT youth and the application of new media and technology to sexual health promotion and HIV prevention. He's going to talk about some of this today. He's really been an innovator in the use of some of the new social media into research, and we're going to hear about that. His work spans the translational spectrum and includes epidemiological studies, the development and testing of HIV interventions, longitudinal cohort studies, which we're in a consortium with him, and those focus on developmental trajectories and risk protective mechanisms. He's been the PI of over $38 million in federal foundational research and training awards and has a very extensive list of publications, I think over 140 at this point, peer-reviewed articles. His current projects include his NIDA-funded dyadic network cohort of young gay bisexual men that seeks to gain a multi-level perspective on the drivers of substance use and HIV prevention in this population, and several randomized controlled trials of HIV prevention for adolescent and young adult gay bisexual men. And he's funded by NIDA and NIMH and NIMH HD. So he also serves as a co-director of the NIH Third Coast Center for AIDS Research, CFAR, and I did not know before that Chicago was considered the third coast. So
yes.
His recognition work include being named a William T. Grant Scholar and getting an award for distinguished scientific contribution to the Society Psychological Study of Lesbian, Gay, Bisexual, and Transgender Issues at the American Psychological Association. So we're really honored to have Dr. Mustanski here with us today, and I will turn it over to him. Thanks.
Thank you. So I'm going to try to go through a lot in 40 minutes or so and leave a little bit of time for questions. As Pamina said, I wear a couple different hats at Northwestern, and one is directing this new Institute for Sexual and Gender Minority Health and Wellbeing, or ISGEM for short. We say we're a GEM, so we pronounce it ISGEM. I want to just talk a little bit, to tell you a little bit about this, which is, as Pamina mentioned, the first university-wide research center in the country focused exclusively on LGBT health. And I also co-direct our CFAR, and most of my own research is focused on HIV prevention. So I'm going to talk a little bit about some of the Institute, a little bit about some of my epidemiological research, and then spend the bulk of the time talking about some of my e-health HIV prevention projects and where some of those are headed. So this is just a brief slide about the Institute. Our goals are really to help grow the field of LGBT health research. It's an exciting time to be doing LGBT health research. For the first time, just this past year, NIH opened the Office for Sexual and Gender Minority Health Research, which is similar to the Office of Women's Health, similar in structure to the Office of AIDS Research, although obviously the Office of AIDS Research is much larger. That serves the function of helping to coordinate SGM, or Sexual Gender Minority Health Research, across NIH. It's a really exciting development. They're now producing a lot of information about how much and what kinds of projects are getting funded by NIH focused on sexual and gender minority health. They fund about $160 million a year in sexual gender minority health research, which to some people is a big number and to other people is a small number, depending on your perspective. But you can actually go into NIH Reporter now and click a tab to pull up a list of all the SGM-focused research projects that are funded by NIH, which is a really nice way to find people who are doing similar research in that area. And so the goal of the Institute is really help to facilitate this research, to forge collaborations between community and researchers. We think to grow this field, this sort of fledgling field of sexual gender minority health research, we need to both grow scholars who's going to have that as their primary focus of research, as well as help connect scholars who might be really established and focused on other health issues that might be interested in applying those research methods and skills to the SGM population. And so our job is to really help facilitate them making those connections. This is a slide that shows the projects that we have going on in our institute right now across the translational spectrum. I'm not going to go through all of them, but I just wanted to give you a sense of the range of projects that we have going on within our institute. RADAR is our large cohort study of young men who have sex with men. Eventually the cohort is going to reach about 12,000 young, or 1,200, not 12,000, 1,200 young men who have sex with men. Some of them have been part of existing cohort studies that I've led in the past, which means that we have over 10 years of longitudinal data on these young men already, which is really exciting, given how little longitudinal data we have on LGBT youth as they're growing up. I'm going to talk a little bit about that project. We also have projects focused on ethics. We have a grant funded by NIMHD focused on the ethics of doing HIV research with gay and bisexual adolescents. What are the ethical challenges of involving them in research with and without their parents' involvement? And really trying to create tools for researchers to think through those issues for themselves. We have a project focused on intimate partner violence in young female couples. And then we also have some things that are more what I would call in the early translation. So I think what I put in the basic science discovery is really projects that are epidemiological, focused on prevalence, focused on developmental trajectories, mechanisms, whereas early translation is really creating interventions. So we just wrapped up a text messaging intervention funded by NIMH to reduce rates of HIV risk behaviors among teenage gay and bisexual boys. The trial was completed. Unfortunately, despite us sending about 8 to 10 text messages a day to these young men for 5 weeks, we didn't show decreases in condomless sex, but we tripled the rate of HIV testing in the group that was assigned to the active arm. So we're going to be building on that perspective in some of our future trials to increase rates of HIV testing. That study showed that only about 1 in 5 teenage gay and bisexual boys has ever had an HIV test in their lifetime. So when you think about HIV prevention for that population, when you think about strategies that are primarily based on ART, like PrEP, or treatment as prevention, if only 1 in 5 of them have ever had an HIV test, those strategies are very unlikely to penetrate into the adolescent MSM community anytime soon, unless we really rethink how we're reaching them with sexual health services. Together is a project funded to Dr. Michael Newcomb that's actually using romantic relationship, sexual health education. We're actually training young men in same-sex relationships on how to have healthy relationships and embedding within that HIV prevention content, which we think is a way to really reinvigorate HIV prevention for young men who are mostly interested in questions like, how do I meet a boyfriend? How do I have a healthy relationship? How do we stay together? How do we keep our relationship happy? HIV is very low on their list of things that they're interested in and passionate about, but having a good romantic relationship is very high on their hierarchy, so we're providing those services to them. And Text to Prevent is a new NCI-funded HPV vaccination intervention for young gay and bisexual men that's using text messages. So that just shows you a little bit of the range of projects that we have going on within our institute. We're very committed to this model of moving things along the translational spectrum. We've really seen how our basic studies really inform the creation of interventions. And as we create interventions and start pushing them out into practice, we're learning a lot of new questions that arise that go back and feed into basic science discovery. And so it's really this cyclical process of discovering and then implementing and going back to the drawing board and collecting more data. That's been a really productive approach for us. Just a few seconds on our cohort study. I'm mostly mentioning this because, as you know, Pamina and Steve have a cohort here at UCLA, the M study. This is a sister project to that called the RADAR study. And what the RADAR study does is, as I said, it's a cohort of about 1,200 young men who have sex with men. We expect to have about 1,000 young men enrolled in the cohort by the end of the year. We have about nearly 900 in the cohort now. And it really builds on a lot of the research that I've been doing with young gay and bisexual men for the last decade, where we've been looking at individual factors, individual levels of analysis. We've studied the importance of romantic and dyad factors. We've studied networks. We've studied biological characteristics. we've studied neighborhood, we've studied development, but we've never really put all of those things together in the same study to understand how development interacts with the neighborhood context, or how being in a particular sexual or drug network interacts with your own individual characteristics to put you at risk. And that's really the focus of the RADAR study, is to have a large enough sample that's geographically dispersed throughout the Chicago area so that we can really start addressing some of those multi-level questions that are much harder to do in smaller cohort studies. And so it involves a biospecimen repository, some research on viral genetics and host immune system. We're following people over time. As I said, we'll have over a decade of longitudinal data on these young men. Some of them dyadic processes. They enroll their romantic partner into the study so we can actually study dyads as they form and dissolve. We have a network science component, and we're also looking at community and structural factors. The guys come into the study every 6 months, and we have over 90% retention of the cohort over time. It's a very diverse cohort. As you can see, Cook County is one of the most diverse counties in the United States, and so we have access to a very diverse racial ethnic population, and so you can see that really is reflected in our cohort, and that's consistent across all of our studies. Usually they're majority minority, and we get very readily about a third African American, a third Hispanic Latino, and a third white roughly across our studies. We have about 55 trans-identified young people that are in the study, as well as the rest are male-identified born male. And the age range is 16 to 29, and you can see given the cohorts that fed into the study, a largest group is the 20 to 24 age group, but also about 40% of the sample being under 20. And that's really important for us because this is really the period of risk for increase in HIV risk and substance use, which means we have data on them before they enter the period of risk, as they move through the period of risk developmentally, and we think that's really important in terms of understanding these developmental processes. 17% of the cohort is HIV positive at baseline, and we have very high rates of rectal STI infections and very low rates of urethral STIs. In fact, the rates of urethral STIs are so low that we're going to discontinue doing urethral STI testing because there's just no point. We're not getting enough data. We only do urethral STI testing in the HIV positive sample. The HIV positive guys have a higher rate of rectal infections, and from prior studies we know they probably have a higher rate of urethral infections as well, which means that the HIV negative guys would probably have an even lower rate. So there's just really very little value for us in collecting urethral STI data, and it's really the rectal infections where we need to focus our attention. I think that has important implications for clinical practice as well, and the extent to which routinely men who have sex with men are getting tested for rectal STIs. One of the things we're really interested in is using this cohort as a way to monitor cultural changes in prevention that are happening over time. We have more than 50 young men that come in for a study visit every week. So we have a unique opportunity to monitor changes as new interventions are rolling out, things like the Orlando shooting. Because we had so many visits, we could look at did people's mental health change in Chicago as a result of exposure to this traumatic event that happened in another city. This is an example of one of our projects that we're in the process of doing analyses now, which is we developed a measure of PrEP stigma that is really related to some of the things that people heard when PrEP was coming out about people on PrEP can't control their sex drives, that really kind of Truvada horror concept that people had talked about, that PrEP is for is for people who are very risky. That it's not responsible, people are being irresponsible by taking PrEP. So we created a measure with a list of items, did some factor analysis, narrowed it down to essentially 2 factors. One is that this real factor of people on PrEP are sort of risky, can't control their sex drive, you can't trust them. And then another item that is really about PrEP is a good idea. And this represents a hotspot analysis of PrEP stigma across the city of Chicago. And the areas that are blue are cold spots, the areas that are red are hot spots. So cold spots are area where there's very low levels of PrEP stigma. And what we see is very low levels of PrEP stigma in the traditionally gay-identified neighborhood on the north side of Chicago. So those young men that live in the Boys Town, Andersonville area, which is on the north side, have very low levels of PrEP stigma. And then we see higher levels of PrEP stigma in other parts of the city. This is a kind of African-American enclave in Chicago. And so we're really interested in sort of monitoring how PrEP stigma is changing in the city. And we're going to be overlaying data on where PrEP campaigns have taken place in the city to see if it's correlated with PrEP stigma. And we're going to be monitoring how this changes over time as PrEP campaigns roll out in Chicago. One of the things that is interesting is that rates of PrEP knowledge don't vary across the city. So guys are equally knowledgeable about PrEP throughout the city, but the stigma is really where we see differences. And we know stigma drives a lot of things when it comes to HIV, so we think this is a really important component when we think about PrEP uptake.
Well, maybe
Yeah.
look at source of stigma. Does it come from a healthcare foundation in the South, or does it come from internal sources?
Yeah, that's a great question of where they're hearing these things. So this is really, in this particular case, we focused on beliefs that the participants actually held. So this was not, I heard people say these things. This is, I actually believe that people on PrEP can't control their sex drive. So these are the beliefs of the young MSM that are in our study. And then it's, on us to try to correlate it with things that are going on, like AIDS Healthcare Foundation Clinic that happens to be actually in that relative area. So those are some of the next analyses that we're going to be doing. So I'm going to shift gears. That's kind of an example of some of our epidemiological, more mechanistic work, and talk a little bit about some of the e-health projects that I've been doing. I'm going to show you some examples from one of them and talk a little bit about where we see this work headed. And share a little bit about why I feel like e-health is an important way of approaching HIV prevention with young men who have sex with men, and show you kind of a series of projects that we've done in this area. So this is CDC data. You guys, I'm sure, have all seen this, epidemiology of HIV in the United States from 2010 through 2014, showing MSM are the only group showing an increase in new infections, which is predominantly driven by increases in the 25 to 34-year-old age group, and to a lesser extent, the 13 to 24-year-olds. This is a group that has showed bigger increases over time, and it looks like perhaps those increases are starting to level out. We were seeing, much higher increases in prior reports, but, are very alarmingly high as it is. Nested within that, we know that amongst 13 to 24-year-olds, that the majority of infections are in African Americans, although we're starting to see increases in Latino, adolescent and young adult men who have sex with men as well. We actually did a simulation modeling project using agent-based modeling to predict the course of HIV infections in adolescent and young adult men who have sex with men in Chicago over the next 15 years. And that was one of the, and we fed into that data from our cohort to inform the parameters in the simulation. And that was one of the things that we predicted was an increase in infections among Hispanic Latinos in the coming years. And I think, unfortunately, we're starting to observe what we saw in that simulation. And I think that really speaks to when you look at the individual and network characteristics that we're observing in Latino young MSM, they're really, everything would predict increases in infections based on their positioning within networks, their individual behaviors. And so I think this is a population we really need to start attending more to. So one of the questions that's really driven my career for the last 12 years or so is the question, or even longer, how do we reach young gay and bisexual men? So I was really interested in how do we reach these young men, while they're going through the coming out process, before they even have sex for the first time? How do we give them the knowledge and skills that they need at the developmentally critical period before they're even putting themselves at risk? And I was really strongly impacted back in the late 90s when I was still in graduate school, or just going into graduate school, a study that did a large survey. It was done by a community organization, which I don't think exists anymore, called Out Proud, that did a large online survey and found that the majority of the LGBT youth in the study had come out online before they did so in the real world. Now that was the late 90s when actually the online and offline worlds were thought of as very separate environments. And most of what people did online was visiting websites, maybe being in a chat room, like an anonymous chat room, which is very different than we have today, where we have Facebook and the social and the online worlds are much more melded. But that study by this community organization had a big impact on me, because I thought, if we can go online and we can reach these young men before they'd even come out to someone in the real world, it's a really unique opportunity for us to give them skills and support at that important developmental transition in a way that we could never do if we delivered the intervention through schools or through community organizations who are reaching these guys a little bit later in the developmental process. And so, that's really been my philosophy. I think the other philosophy has been that we know that a lot of the settings where sexual health services are delivered for young people, like schools, are really resistant to messages that are attuned to the needs of young gay and bisexual men. We know that there are actual states who have these, quote, no promo homo policies, which means you can't say anything about gay people in the school, and if you do, it has to be negative. You can't do good sex education for young gay people if that's the policy of the state that you're living in. And so my philosophy, again, was if we delivered content online, we could create the content that we think best reflects what the evidence says is effective and not have to worry about vetting it through school boards or school health committees. We could really deliver the content right to the young people. So in 2001, I published this paper, really one of the first papers about using the internet as even a way of collecting data. And there's been something I've really been studying since then, is both how can we use the internet as a means of collecting data, as well as how can we use the internet as a way of delivering sexual health services. At the time, most of what had been written about the internet was really about the internet as a risk venue, talking about syphilis outbreaks online, talking about gay men hooking up through the internet, and really everything had this very negative and dire perspective that the internet was sort of ruining people's mental health and leading to people to hook up and disease transmission. And I was really more interested in how can we use it to do research that we couldn't do before, as well as how can we deliver sexual health services in a way that could never be done before. So my first study, which actually ended up being my dissertation study, was a diary study where I followed a group of gay and bisexual men for a month, and they did online diaries. This was back in the day where Qualtrics and SurveyMonkey didn't exist. I actually had to write the code to do online surveys because there was no survey software that even existed back then. And so it was a diary study where essentially we asked people every day to report on their sexual behavior, how they met that partner, other characteristics like substance use with that partner, and every day they would fill out the diary. We hit a really high compliance rate. Part of this was people had not done online research before, so people were actually really excited to be in an online study, if you can believe that today. It was a different era back then. But what we found, and I actually found a picture of a Windows 98 computer, because that's probably what people were using at the time, that even back then in the mid-2000s when this data was collected, about 30% of partners were met online. That number is obviously higher today than it was then. But still, we found about 30% of partners were met online. And in this context, most people were talking about guys who meet partners online have more partners, engage in more risk behaviors, more likely to have an STD. And in fact, that's what we found. If you compare people to each other, if you do a between subjects comparison, we found, in fact, that guys who went online to meet partners did have more partners, had more acts of unprotected sex. But when you actually compare the person to themselves, meaning when you look at how did they behave when they met a partner online versus when they met a partner through another venue like a bar or club, we actually found that they were 60% less likely to have condomless sex with a partner they met online than a partner they met through another means. So this is one of those interesting examples of a difference between a within person and a between person effect. If you compare people to each other, if you go online to meet partners, you're more likely to be risky. If you compare that same person to when they meet partners online to when they meet partners other ways, they're actually less risky with the partners they meet online. And I think it makes sense because if you ask people, do you go to bars to meet guys? Do you go to this place to meet guys? Do you go any place to meet guys? People who do that are probably going to be riskier than people who say they don't do that. Just the very interest in wanting to have sex is going to mean you're probably somebody who has more sex than people who have less interest. It's really the within-person comparison that's the most important. So, this was some of the formative research that I had been doing for a while on how people were using the internet. Yeah?
I'm curious about your interpretation of that. I would think that people online know there's time difference, but online would be more risky. Once you've established and met somebody, even if it's 3 seconds, there's a person.
Mm-hmm.
Whereas that is a person. So why are you saying it's the other way around?
What we find essentially, if we try to unpack that effect, it's about familiarity. If people meet somebody through a friend or at a party and they have sex together, they feel like they know that person. And so they're less likely to use a condom. If they meet somebody through the internet, they feel like, I don't trust this person, it's just a hookup. I don't know if they're safe or not, and so they're actually more likely to use a condom when they meet somebody online because they have less trust in that person. We think trust is a big mediator of that effect, and it's kind of borne out in some other studies we've done over time. So now I'm going to switch gears and talk a little bit about one of our online HIV prevention programs called Keep It Up. And it's focused on young men who have sex with men that recently tested HIV negative. And I'll just share a little bit about why we decided to target this very specific group of young MSM that tested negative. As I shared with you before, the prevalence data suggests that they're a group that's at high risk for HIV. They're a group that has lack of prevention programs. You know, we have very few, even to this day, a decade after I started this work, we still have few HIV prevention programs that are targeted at young men who have sex with men, particularly relative to other much lower risk groups. I was really interested in how do we target a diverse sample. We know racial ethnic minorities are disproportionately impacted by HIV, and most online HIV research that had been done had very little involvement of people of color. And so I was really interested in how can we do this kind of work, but still make sure that we're recruiting people of color to have an opportunity to participate. And my hypothesis was that if we link it to an HIV testing visit, if it's the HIV test counselor that tells them about this online service, they may be much more likely to participate than if they were just recruited online, and they might have more suspicion about who's conducting the study, who's providing the data, what's the source of the information. And that was one of our main drivers for linking it to an HIV test, is we thought the counselor was an important person to sort of make that bridge. We obviously know, I mean, back in the day, we used to worry a lot about who was online. When I wrote this grant, I had a whole section saying, trying to convince the reviewers that, you know, young MSM use the internet. Of course, you don't have to write that section of your grants anymore. And I also think that testing is an underutilized opportunity for prevention. I can just say, in my personal experience over time, having many HIV tests in my life, there's been times where I've gone and got an HIV test, and if the result was negative, you know, the counselor would tell you in the lobby, you're negative, you can go. You know, that was the end of it. And there's other settings where there's actually a lot more risk reduction counseling that happens and focuses on keeping that individual negative. There's a lot of variability across agencies, even within agencies. And I think this is a missed opportunity because these are individuals who came in for an HIV test. HIV is relevant to them. They think they must be at risk in some way enough that they decide to go and get an HIV test. And so it's an opportunity for us to deliver prevention programming to a group that it's relevant to. I'm going to kind of take an aside a little bit and talk a little bit more about testing and why I'm focusing on it. You know, we know testing is a key component of the National AIDS Strategy. We know that you know, it's increasingly being one of the major goals for HIV prevention activities in the United States. The CDC recommends that MSM get tested for HIV at least once a year, and that sexually active MSM should get tested somewhere between 2 and 4 times a year. That's a lot of testing, and the data suggests that there is a lot of testing that happens. In our young adult men in our cohort, it's not unusual that we see guys who've had 5 to 10 HIV tests in their lifetime. I think we really have to think about that, because what does it mean to do something that you worry about in terms of risk? You go in and you get a negative result. You might engage in another risk behavior. You go in and get a negative result. What is the psychological impact of that pattern of experiences? And it's actually been not very well studied. So most of the research that's been looked at the impact of HIV testing has been on people who test positive, which several studies have shown that when individuals test positive, there's a trend towards decreasing HIV transmission behaviors. The meta-analyses have shown pretty much inconsistent or no effects on those who test negative. So testing negative it's pretty clear it doesn't reduce your risk-taking behavior when you test negative. And there's actually been a few studies that suggest that it may increase your risk behavior. So there's been some research showing that guys who've had repeated negative test results were more likely to get STI, or more likely to have STIs later. Now, is it because they're engaging in risk behaviors and they're getting testing appropriately, and therefore that's where the STI is coming from? Or is there some psychological impact of those repeated negative test results? As I mentioned, you know, we're in this somewhat newish area. I don't know if that's a real word, but I'm going to use it. A newish area where MSM might be tested dozens of times in their lifetime. That's a different era than we were in before. And again, what is the question of not using a condom or PrEP, testing negative, not using a condom, PrEP, testing negative, not using a condom or PrEP, and testing negative? What's the psychological impact of that. We know from operant conditioning that repeated pairing of some pleasurable behavior like unprotected sex with no, quote, punishment like a negative test result could reinforce engagement in that behavior. But we've done very little to study the impact of repeated testing negative. And so we developed a scale, which was just published in Annals of Behavioral Medicine in 2014, that asked questions about how people reacted to a negative test result. So we did an online survey of men who have sex with men, and we asked a whole bunch of items. We did some qualitative interviews, first of all, with guys who had just tested negative to ask them, how did you react to testing negative? And we took that information from the qualitative interviews and we developed a list of items that asked about reactions. And we found that essentially in this particular survey, it shook out to be 3 particular dimensions of how people react to testing negative. One is a sense of reinforced safety. Testing negative means my safer sex behaviors are working. It encourages me to keep practicing safer sex. There's another dimension of luck. People saying testing negative made me feel like I dodged a bullet. I felt lucky that I got a negative result. This is a concept that doesn't have a lot of agency for the individual. It's up to chance whether you get infected or not. And testing negative showed I was a lucky person. And then there was another group that had this sense of invulnerability. When they tested negative, it said, I'm less worried about contracting HIV. I feel like maybe I'm one of those people who's immune against getting infected with HIV. It must mean that maybe it's more difficult for me to get infected. I feel invincible against the disease. That's a concerning pattern in terms of thinking about future behavior. We actually, and I'll say in this paper in Annals of Behavioral Medicine, you'll see that these variables did relate to self-reported condomless sex behaviors in the ways that you'd expect. And they interacted with the number of tests that you had. So the more tests you had in your lifetime, the more impact that these variables had on your behavior. Now, this was an online sample. Some of the guys had been tested in the past. Not everyone had been recently tested. So we recently revisited this in a sample of guys that had recently been tested. Everyone had been tested within a few weeks of filling out the questionnaire, most just within a few days of filling out the questionnaire. And we redid the factor analysis, and we actually found in a sample of guys that recently tested negative, there was actually a 4th factor that represented the concept that testing negative means they're justified in actually having more condomless sex in the future. And that was items like testing negative means I don't need to protect myself. It means I should have more condomless sex with casual partners. And that a 4th dimension occurred when we looked at guys who had just tested negative. And we found similar interactions with number of lifetime tests. So the guys who had the most tests in their history, and I don't remember exactly how many that was, but I think it was like 5 to 7 tests, showed a bigger relationship that this sort of reinforced safety, if they were low in that belief that testing negative reinforced their positive future risk reduction behaviors, they were the most impacted, the guys who had tested the most. And similarly for that luck concept. So I think this also has impact for organizations that do a lot of HIV testing. This is an easy questionnaire to administer. You could quickly derive some information about the reaction that someone's going to have to that negative test result, and you could provide them with tailored feedback to sort of combat some of those beliefs that we think put people at increased risk. This new analysis was just published in AIDS and Behavior. So this was all an aside about how people react, because it gives a little more information about why I'm so focused on delivering interventions to people who just tested negative, because we think that this keep it up intervention, which the whole concept is keep it up and maintain your negative status, is really important for guys, particularly in an era where there's more and more HIV testing occurring. So this is a publication in AIDS and Behavior where we talk about the qualitative interviews that we did with diverse young MSM to develop the content for the intervention. We did qualitative interviews. We co-created the content with diverse young MSM. We had constant feedback from community-based testing staff who were actually involved in creating the content with us. And one of the things that's unique about the Keep It Up intervention is that it embeds all of the health behavior messages within different contexts that young people find themselves in. So, traditional HIV prevention intervention is session 1 is HIV is a virus and here's how it's transmitted. Session 2 is, use a condom. Session 3 is drugs and alcohol, et cetera. This is more about dating. It's about going to bars. It's about hooking up online. It's about the different contexts that people are in. And then we embed the messages about how do you enact these risk reduction behaviors within these different contexts. And Keep It Up has been studied in a number of projects. So Keep It Up 1.0 was a R34 to essentially develop and do a small pilot test of the intervention and demonstrate feasibility and acceptability. We were then funded by the Chicago Department of Public Health to implement Keep It Up in Chicago as a service project in partnership with community organizations. And we had several hundred young MSM that received it as a service project with further evaluation. This was actually funded to our community partner center on Halstead. We did the evaluation piece, they delivered the intervention, which worked really fantastically. And then Keep It Up 2.0 is an ongoing trial funded by NIDA and NIMH to test the efficacy of Keep It Up in Atlanta, Chicago, and New York, as well as an online sample that did home HIV testing. And one of the things that's innovative is we're following these guys for 12 months. They do self-report endpoints, but we're also doing rectal and urethral STI testing through the mail. And those are our biomedical endpoints for the trial. So I'm just going to show you a little example of the type of content that's in the Keep It Up intervention. I can't go through all 6 modules, so I'm just going to show you a little pieces of 2 of the modules. One of the things that came up from our focus groups and our engagement with the community in creating this intervention is that guys really don't want an HIV intervention that just starts by talking right off the bat about HIV. It implies that all we care about, or what Ron Stahl is, we pretend like Ron Stahl often says, all we care about is the area between the knees and the navel. We pretend like there's nothing else. And so that's one of the things we wanted to combat right off the bat. So we start with what we call person on the street interviews, where we interview guys about their connection to their community, their relationships with their family. And one of the things that we do is, because we know context matters, people feel connected to their local context, each city produced its own videos that start off the intervention. And it's very easy to do. We just had people take a flip cam, go on the street and interview people. It helps if you have a cute dog that people are willing to come up and talk to you when you're trying to do these interviews. And so I just wanted to show you the video that's focused on romantic relationships from Chicago.
I like being single because I'm not tied down, I don't have any obligations to anybody, and I can find out what I need for myself first and then find it.
I love that I can go home to somebody every night and have somebody that I can come with and be with. So many games I like to go over to the bar like every night and sleep with different people, and that's just not fulfilling to me. I like that I have that security and I know I can go home to somebody.
I don't like being lonely. I'm the type of person that needs to have someone around me. So when I have my guy around me, I feel like there's nothing good I'll take away from him,
It's nice to be able to do what you want to do when you want to do it. And, obviously there's a lot of times when it's kind of lonely, but it's, you're free to do what you want to do, so.
I like to be able to do whatever I want to do anytime I want to. I have somebody to call and check on all the time.
That's a stalker.
That's a stalker.
I like the peace of mind that it gives me. I like knowing that I'm being responsible.
Keep you protected, safe, drug, disease-free.
Yes.
I like wearing condoms because, again, there's like the safety aspect. Sometimes you get into the colored ones, and then it's just like, it's fancy, And like, then you don't get gonorrhea.
Thank you.
So that's you can see there's a lot of humor in these videos, and it's a lot of stuff you wouldn't get if we had actors doing it, reading scripts. It's just, when that guy turns to his friend and goes, "That's a stalker," it's just like the funniest thing ever. And these guys talking about condoms, I think it really breaks through some of the hesitancy people have to have these kinds of conversations by using humor. Module 2 focuses on hooking up online. You can see our great 7-year-old animation illustrations here. Obviously, we'll be refreshing those in the future, but goes through and talks about some of the skills you need when trying to meet partners through the internet. We have a soap opera that follows a group of guys and highlights really the risks in making assumptions about someone's HIV status, making assumptions about monogamy in your relationship, making assumptions about, and really the limits of serial sorting. We have a virtual club that people go into and interact with different characters, and when they're interacting with them, they kind of engage in different learning processes, particularly about the role of substance use in decision making. And we have a lot of content on dating and communications because we know that romantic relationships are really the context where most condomless sex occurs. We see very little condomless sex with casual hookup partners. Young men really have gotten the message that use a condom when you hook up. It's really as soon as they think that it's a serious relationship, that's when the condom comes off. Also, unfortunately, when they think it's a serious relationship is when they don't think they need to take PrEP. And so those are really the guys that we think are at most risk. And so we have a lot of content that contextualizes HIV prevention in the context of a romantic relationship. At our 3-month booster, we have another soap opera following some guys dating that are a little bit further on in their relationship and are trying to make a decision about should they stop using condoms now that they've been together for a while, and kind of walks through some of the things that you'd want to think about if you were thinking about discontinuing condom use. One of our philosophies, and keep it up, and we keep saying it over and over to the guys, is we're not your mom. We're not telling you what to do. We're here to give you the information and you decide for yourself, but we want to help you think through, what could be the right decision for you that would meet your physical needs, your sexual needs, and your health needs. So the pilot was all guys who were recruited through several different HIV testing clinics in the city of Chicago. So all of these guys came from face-to-face community testing clinics. Big shout out to Howard Brown Health Center and Center on Halstead, which were both involved in helping us with this project. There were 102 guys who were randomized. 81% of them completed the intervention, which we were really happy about. And then we had really good retention at the 6 and 12-week follow-up assessments. It was a diverse sample, majority minority, mostly gay identified. And they couldn't be in a serious long-term monogamous relationship to be in the study. So some of them were in, by the end, or some of them identified as being in a monogamous relationship, but also had outside partners, which is an interesting definition. What we found at the 3-month follow-up compared to the control arm, the Keep It Up arm, and I should say the control arm was an active HIV education arm. It was essentially the type of HIV education you get if you went to the CDC's website and looked up what the facts are about HIV. So the control arm was educational. We saw both arms had a significant increase in HIV knowledge, but the Keep It Up arm combined that knowledge with these behavioral skills and motivational content. And we found at the 3-month follow-up, the Keep It Up arm had a 44% lower rate of condomless anal sex acts at the 3-month follow-up compared to the control arm. So we're really happy about that effect, even in this small trial. Of course, small trials are prone to variability in effect sizes, so it really was here to demonstrate the acceptability and feasibility. Acceptability rating was very high. People really liked the intervention. Here's a quote from a participant. I was able to see mistakes that I made in the actions of the characters. I wasn't completely aware of my behavior until I judged a character's behavior and then compared the same behavior to my own. As an educational game tool, it's superb in its credibility and fun interactivity, cool animations, and real-world mini-films, the future of gay sex ed, which is like my favorite quote of all times. I put that all over our website when we're trying to recruit people. As I mentioned, Keep It Up 1.5 was a service project that was actually delivering this intervention in the community as an HIV prevention program for young men that just tested HIV negative. I don't know off the top of my head the number. It was several hundred guys that went through and got the intervention. Very successful in terms of its delivery, in terms of finding guys and getting them engaged. A lot of things learned about how to implement an e-health intervention in the community through this implementation trial. We basically did a pre-post test on the guys who completed the intervention and we were able to retain for follow-up to look at things like HIV knowledge, behaviors, condom use, and intervention acceptability. So there were 977 YMSM who were screened, 755 who were eligible. Only about half of the guys completed the intervention. This is the reality when you take things into the community, when you don't have the resource of an RCT to follow up with people all the time, you don't have the incentives for people to complete things. But nevertheless, that's 343 guys in Chicago who got an e-health intervention that wouldn't have had access to it before. And we think that the guys who completed it were the guys that it was most relevant to. So just like anything else, people use something when it's of relevance to them. And so we're actually not that bothered by the completion rate. We think it's actually a good evidence of how this would work if it was implemented in the community. If you look at the guys who completed the follow-up, you'll see that there were significant increases in HIV knowledge, significant reductions in condom errors and condom failures, fewer total sex partners, fewer casual sex partners, and fewer sexual condomless sex acts with casual partners. So we're really happy about the impact of this intervention when it was delivered in a community setting. And in fact, the effect size is slightly larger in this implementation trial than it was in the RCT. As I mentioned, we're now evaluating this in a 3-city randomized control trial in Atlanta, New York, and Chicago with STI endpoints. One of the things that I'll say about this is it worked incredibly well to do the at-home STI testing. We ship people a little kit. When they open up the box, it has like a nice little letter for them. There's a bunch of supplies. They unfold a little placemat that has places where they put the urine cup, the collection equipment, and really kind of walks them through everything they have to do. So it's really user-friendly. They do a rectal swab. They provide a urine sample. They ship it back to the lab. We give them a box with a label. Super easy for them to do it. And in our exit interviews with participants, the STI testing was one of their favorite things about the intervention. And I actually think if we hadn't done STI testing, we'd have a lower retention rate, because a lot of the guys really valued it, particularly the opportunity to get a rectal STI test, which is often not available to them in other settings. Just for the sake of expediency, I'm going to move through this, but essentially the way the Keep It Up 2.0 recruitment works is at the end of the the HIV test, the counselor says, I have a program that I think could be good for you to do. If you want to learn more about it, they can hand them a tablet. It has a brief video by one of our medical students who narrated a little welcome video about the project, and the tablet sort of takes them through the rest of it in terms of enrolling in the trial. So it's very low burden, or can be very low burden to the counseling staff, which we know is important. As I said, we have a pilot where we had 144 guys that we actually enrolled online and mailed them at-home HIV test kits. It worked very well. We had very few problems with doing this. And so far, the evidence is that our retention rates are even higher for the guys that we recruited online than the guys that we recruited offline. So I think, again, we're building an evidence base for the possibility of combining this e-health intervention with some clinical at-home projects like self-testing for HIV and STIs. Similar to our other study, we had a very high rate of rectal STIs. In this case, 13% of them had a rectal chlamydia or gonorrhea infection, with chlamydia being the more frequent than rectal. And we found fairly low rates of overlap of rectal and urethral STIs. Related to a discussion we had, Femina had hosted a meeting here at UCLA on measuring HIV risk. One of the things we've looked at is how well does self-report behavior predict whether you have an STI. There's obviously skepticism sometimes about self-reported behavior. Self-reported condomless receptive anal intercourse is a major predictor of having a rectal STI. So there is that's one way of sort of validating our approach to collecting that self-report data. So just to wrap up, a couple of implications and next steps. We've shown that the Keep It Up intervention can engage diverse young men who have sex with men, who are traditionally underrepresented in research, and we're in the process of examining these effects over 1 year on condomless sex and STIs. Our observations in the pilot study, the community-based implementation, show that Keep It Up can promote health behavior change amongst diverse samples, and it's feasible for community organizations to deliver this intervention within a city. We've shown some evidence about the possibility of integrating self-testing into an e-health program. And one of the things I'd really like to explore in the future is how do we link this up to, say, PrEP delivery? You know, there's a idea, a mandate that you should do risk reduction counseling with folks on PrEP. It's there's challenges of doing that within a clinical setting for providers to provide that risk reduction counseling during a brief check-in over time. How could we use e-health approaches to continue to deliver information and risk reduction counseling and STI testing frequently, which is very difficult for people when they can't come into a clinic maybe every 3 months. Can we facilitate some of this happening at a distance? We're in the process of talking to a foundation now about implementing what we call Keep It Up 2.5, which is a slight update to the Keep It Up 2.0 content in several different cities. And we just were happy to find out about 2 months ago that we got a very large grant, a U01, from National Institute of Minority Health Disparities to do a large nationwide HIV prevention online intervention with teenage gay and bisexual boys, 13 to 18. and really focused on delivering content to racially ethnic minority populations. All of the content is going to be delivered in English and Spanish, which we're really excited about as well. And we're using a stepped care strategy, which means that all of the guys get universal sex education through an intervention I developed in the past called Queer Sex Ed. If they don't benefit from that, meaning they're not using condoms when they have sex, not on PrEP, not intending to do either of those things, they get up to the Keep It Up intervention, which is going to be developmentally adapted for this younger population. If they still don't respond to the Keep It Up intervention, they actually get stepped up again to individualized video chats using motivational interviewing to really address their specific barriers to engaging in HIV prevention behaviors. So I'm just going to wrap up, and I'll hopefully save like a few minutes for questions. I want to announce that I welcome people thinking about coming to our National LGBT Health and Wellness Conference that is in its 5th year. It's been growing every year by leaps and bounds. Last year we had it overlapping with APHA, and we had hundreds of folks come. We've held it in the past in the Center on Halsted, which is our community partner. We may have not enough space anymore to do that, but it'll be in Chicago, April 28th to 30th. The save the date is out. We'll be announcing a call for abstracts very soon. We just found out, 2 days ago, NIH is supporting the conference, CDC is supporting the conference, American Foundation for Suicide Prevention, and our CFAR are all supporting the conference. So it's going to be a great national meeting, really good for early career folks, really focused on bridging research and practice. So community partners, clinical providers, researchers coming together, focused on HIV prevention, focused on LGBT health. And in conclusion, thank you to my funders, thank you to my amazing staff who make all of this work possible. I encourage you to check out our Impact Program website. We have a major commitment to disseminating knowledge directly to the LGBT community, and we have an award-winning website, impactprogram.org, where we create blogs and videos about our research to try to share it. This is a campaign we did for National Youth HIV/AIDS Awareness Day, focused on what it's like for young people living with HIV, and there's a lot of really great videos and content that's all publicly and freely available. So encourage you to check it out. The other thing I would say is this is a great sandbox for us, our website. As we're trying out new e-health, new ways of delivering information, our website is a fantastic tool for us to sort of test things out and see how it goes before we put it into a standardized intervention. So it's nice to have that kind of resource. And that's it. So this Keep It Up study is 18 to 29-year-olds, so it's not an adolescent sample. We did ask them to provide us the address that they wanted it to be mailed to. That was a separate, part of the process. Each time that a kit was mailed, we asked them what is the address they want. So they didn't necessarily have to have it mailed to home. I'm not sure how many people used addresses other than their home address, but we really had very few challenges. This process actually worked exceptionally well.
Yeah, Brian, congratulations on the breadth of all your work and kind of, leading this whole e-health prevention forward. I mean, for 30 years, people have been researching, behavioral, group, individual, all sorts of different delivery systems to change human behavior. And, you are now including biological outcomes, so kudos for that. What do you think is unique about this intervention, or different, or how have you built on the 30 years of people working?
Mm-hmm. Well, I think a couple of things. I think one, we always have a new supply of young MSM coming into the world, and unfortunately we do a terrible job of giving them any kind of sex education in school that's relevant to them. So I think we have to keep that in mind, that maybe what's worked in the past, what we've delivered to people who are older, isn't reaching this population. And so I think that's just a critical thing, is they're not, they have a lot of, this group has a lot of misunderstandings about HIV and how it's transmitted, and, beliefs that if I'm the top, I don't have to worry about HIV at all. It's completely irrelevant. Things like that are sort of roughly related to some evidence, but are not factually accurate. And so I think it's critical that if we want to address this growing rate of HIV in young people, that we really address this population who has not been targeted nearly at all with HIV prevention messages, has not been represented in that 30 years of research. I think there's evidence that these behavioral interventions can have positive impacts. We've had very few trials with biomedical endpoints of behavioral interventions that have been powered to detect effects. I'm quite concerned actually about a generation of projects that were funded and are about to produce results that were very poorly powered for their biological endpoints. And so I think we probably over the next few years will have a number of behavioral trials reporting outcomes that may show effects on behavior but not STIs or some other biomarker, and they've been terribly powered to find those effects. So I think that's going to be a concern that as a field we have to grapple with. But we are powered to detect effects. Luckily, because we added rectal STIs, I don't think we would have been powered sufficiently just for urethral STIs. And so we will be able to see how this works. So I think that the other, innovation is the Achilles heel of behavioral interventions has been scale up. You can get them to work, you can change people's behavior. We've got plenty of evidence that's the case, but they're not getting implemented in the right size, in the right quantities, and to the right people. And so I think that's the other thing that's good about the e-health approach, is that it doesn't completely take that off the table. It's not like I just upload this and it gets disseminated to everyone, but it changes the formula in terms of thinking about implementation. So.
Research among the young non-health sector in China. I found that there's a similar problem or similar phenomenon in your study, that it's very difficult to recruit the participants and have them retain in the longitudinal study. Like you have someone just refused, don't want to partake, and you just followed for 3 months. Like my study followed for 6 months, there's almost 36% lost during the 6 months. So do you have some strategies or some experience how to maintain them in the longitudinal study?
Yeah. Well, in our longitudinal research studies, we routinely have probably over 90% retention. It was in this community implementation of Keep It Up where we struggled with retention, and I think that speaks to what's the difference that's done when it's done as a research study versus when it's implemented in the community. When we've done these as research studies, we've had the resources to have study staff frequently get in touch with participants. So, if it's a study that they do a study visit every 6 months, we probably talk to them 2 or 3 times between study visits, check in, do we still have your contact information, how's everything going? And so we're really, that's really critical for retention. We don't have those resources often when they get implemented in a community setting as sort of public health practice where resources can be quite scarce. So I think that's a big part, is sort of frequently getting in touch with people. We don't want to find out 6 months later that somebody's contact information is out of date. That's why we frequently get in touch with them, because we want to find out very quickly if we have a problem with our contact information so we can use other means, to get in touch with them. Oftentimes we ask them if there's a friend or a family member that we can get in touch with if we have trouble contacting them, and we find that to be really acceptable to them. We ask about multiple forms of contact, so can we reach you through Facebook? Can we text you? What do we do if your phone stops working? Is there someone we can call, even if we don't tell them what the study's about, and we just say, hey, can we call somebody and say, we're trying to get in touch with so-and-so, the phone isn't working, do you have a new phone number? So I think that's one of the things that you really have to do with this kind of research to stay in touch with people. Yeah? Mm-hmm. What? Yeah?
I don't know whether I missed it, but thank you for a wonderful presentation first. But Keep It Up, how many sessions were in there, and then what percentage of participants complete all the sessions?
So for the trial, there are 3 modules that they do at baseline, each of which has about 30 minutes of content, 20 to 30 minutes of content. They have to do them at least 24 hours apart because we want to sort of stretch out that learning experience a little bit. So they have to log in at least 3 different times to do the baseline content. There's then a booster session at 3 months and 6 months that both gives them a chance to get access to the original content and provide some new content For example, there's a new soap opera that comes at 6 months. Retention in the trial is excellent. Over 90% of the guys do all of the content in the trial. It was lower, obviously, again, in the community implementation where we didn't have the resources to keep following up with people and reminding them to do things, essentially.
So it's fairly low potency
Yeah.
intervention.
Yep. Yeah, it's not, 6 sessions, hour each. It's, maybe 90 minutes of content at baseline and then 30 minutes of content each at 2 boosters.
Do you think that contributes to the success?
Yeah, I think it gets right to the point, we don't have to do introductions and we don't have to do icebreakers and things like that you do in a small group intervention. We just get right into it, and I think it's, I think that's part of what people like. We get mixed feedback about forcing them to come in multiple times online. Some of the participants say, well, I like it because it forced me to really take the time to go through it. If I could have done everything at once, I probably would have just rushed through it. Other people are like, well, you make me come back 3 times. Can't I just do it all at once? But I do think that there are some meta-analysis suggesting that behavioral interventions are more impactful when you make people have multiple interactions with the content, and that's part of the reason we force people to come and go through it at least at 3 different time points. Peter? Thanks.
Why do you think these kids even care about getting positive?
Well, that's a great question. I think it's still scary to them. I think there's a lot of, they have a lot of sense of the stigma of HIV still, and a lot of worries about how would I tell my parents? How would I tell somebody if I was dating them? I think they have not a lot of information about what it's like to live with HIV, what's involved in the medications. Some of them still talk about it as like not, ways people talked about it 20 years ago because they know so little about it. I think it's a lot of the same things that people worried about in the past.
There's such a rising amount, and again, you have the data, I don't, of up to 1 pill a day. Who cares? They live as long as HIV positives on medicines. I don't have to worry about it anymore.
We don't see that in young people. So we did a survey about like HIV prevention fatigue. Are you sick about hearing about HIV prevention? And very low endorsement of those items in this group.
I've been in West Hollywood, there are 2 or 3 support groups for HIV negatives because these people really want to stay negative and they don't have anybody to go to because this idea about, well, maybe I just want, the bug chasers are the old words, but they actually, why?
Yeah.
If it happens, it happens. I take the pill. There is we used to be a 3-month period, 3-year period of, oh my God, what do I do? It's down to about a month and a half or 2. But they also agree, there's a whole thing in the underprivileged, especially drug impacted. When you're HIV positive, you get all these benefits in terms of rehab and ongoing support, and the disparity is so obvious, these folks. I'm seeing the rise in patients that say, why should I be so worried? If it happens, it happens. It doesn't.
Yeah.
So it's interesting that you say that you're seeing it differently. You're studying it. I'm just like.
Yeah. Yeah, I think that the younger group are just totally different than what we're seeing in older populations, and that's why.
I'm talking about 18 to 24-year-olds.
Yeah. Huh.
They don't. I know it's a ridiculous question to be asking in an HIV setting. Why do they care? But I think it's actually a really important thing because I'm seeing a lot less folks really care the way they used to.
Yeah.
And some of it's the 1 pill a day, and it's been probably by the availability of PrEP.
Mm-hmm. Yeah. No, it's interesting because ultimately, if you can't answer the question of why people should care, if I can't answer the question of why they should care, why should they care of doing my intervention? Why should they care about doing any of these things? I think it is important to keep asking that question.
So, from your data, about what % of the people who view your videos and participate in the intervention are appropriate for PrEP?
That's a good question. We haven't done that analysis. I would say probably for the Keep It Up trial, nearly 100%. They're all guys that had condomless anal sex in the 3 months before they were enrolled in the intervention with a male partner. So I think that gets them most of the way to being eligible for PrEP.
So one of the follow-ups to that is, building on your point, Peter, is that many of the people who seroconvert who are young have structural determinants of health that are missing in their network.
Mm-hmm.
So they really need some sort of case management or some human being who's involved. So are you building linkages so that you have a human being who can reach in and get that person to healthy eating or sleeping?
Yeah.
Or, sort of things?
Yeah, I mean, I think that that's where, with this new trial, that's new UO1 that we just got, I really am interested in moving into the stepped care model, which is the idea that, for some young people, for some people, maybe just text messages or maybe an e-health intervention, maybe some education, that might be all they need, and that might work for a certain proportion of the population. And then there's other people who need more. And, from a resource allocation model, if we can get some people through with just some education, that's great because that means we can put more resources into the people who need something more intensive, like individual counseling or some kind of case management service. And so that's a big focus of our next trial, is really who benefits just from this education, behavioral skills, and who really needs something more, and do they benefit more from that motivational interviewing if they get to that point in the cascade of needs. I think that's really where we need to be moving, because this isn't going to work for everyone, but it's going to work for some people. Very low cost in delivering this. Let's get this to the people that would benefit from this, and then let's save our resources for more individual case management, counseling for the people who that's what they really need. So that's where I really want to take this stuff next. And I think we're a little over time, so we should probably wrap up.
So,
Thank you.